Okay, we spent a lot of time talking about long QT syndrome, where the heart's electrical recharge takes too long. Now let's completely flip the script and talk about short QT syndrome. It's rare, but just as dangerous, isn't it?
Absolutely. It's the mirror image, and equally, if not more, dangerous in some ways. Short QT syndrome, or SQTS, is another rare, genetically determined, autosomal dominant cardiac channelopathy. But instead of a prolonged electrical reset, it's characterized by a markedly shortened QTC interval on the ECG. The heart recharges far too quickly. This incredibly rapid repolarization significantly raises the risk of life-threatening arrhythmias and sudden cardiac death. The first reports linking a shortened QTC to an elevated risk of SCD emerged in 1993, and its genetic underpinnings were further clarified in 2000. It's a very intriguing condition because it defies the conventional understanding that a faster heart reset would be better.
So if long QT is about delayed repolarization, what causes the heart to recharge too quickly in short QT syndrome? What are those faulty electrical gates doing this time?
In SQTS, the problem is also with those tiny electrical gates, the ion channels, but the effect is the opposite. Instead of slowing down, they speed things up. In some subtypes of SQTS, specifically SQTS 1 through 3, there's a gain-of-function mutation in potassium channels. This means these potassium gates open too wide or stay open too long, causing potassium to rush out of the cell much faster than it should, abruptly shortening the electrical action potential. It's like a circuit breaker tripping too quickly. In contrast, SQTS 4 through 6 involve loss-of-function mutations in calcium channels. Here, the calcium gates don't let enough calcium into the cell, which also contributes to that rapid repolarization and action potential abbreviation. There's even a novel subtype linked to mutations in the cardiac chlorobicarbonate exchanger. The overall result is a severely shortened QTC, very brief effective refractory periods, meaning the heart can be re-excited too soon after a beat and increased transmural dispersion of repolarization, creating a perfect substrate for reentrant arrhythmias. It's genotypically and phenotypically heterogeneous, with 7 subtypes identified so far.
The clinical picture for SQTS is quite stark. About 40% of patients might be asymptomatic, meaning they have no obvious symptoms until a catastrophic event. Among those who do show symptoms, cardiac arrest is frighteningly the most common initial presentation, occurring in 28% of cases, and it's also the most frequent symptom overall, with a prevalence of 34%. Sudden cardiac death occurs in about 4% of patients during the first year of life and shows 2 incidence peaks, one in infancy and another between the 3rd and 5th decades of life. Other notable manifestations include palpitations, dizziness, and syncope. Triggers vary by subtype. For example, SQTS1 patients often have events triggered by exertion and emotional stress, while SQTS3 has been associated with nocturnal palpitations. Interestingly, a systematic review revealed that the incidence of cardiac events in SCD and SQTS patients is significantly higher among women.
How does this rapid recharge manifest on the ECG, and are there any nuances to its measurement that make it tricky to spot?
That's a great question, because it's not just about a short QTC, it's also about how it behaves. A key characteristic of SQTS on the ECG is that the QTC interval remains relatively constant, regardless of heart rate changes. This is quite unusual. Normally, the QT interval prolongs when your heart rate slows down and shortens when it speeds up. But in SQTS, the QTC shows inadequate prolongation during bradycardia and excessive shortening during tachycardia, a phenomenon we call pseudonormalization. This distinctive pattern is a huge diagnostic clue, especially when confirmed with serial ECGs, Holter monitoring, or treadmill testing. For optimal accuracy, experts recommend obtaining ECGs at a heart rate of approximately 60 BPM. Additional ECG findings include the shortening or even absence of the ST segment. Tall and peaked or sometimes biphasic T waves and prominent U waves. Atrial fibrillation, premature ventricular contractions, ventricular fibrillation, and cardiac arrest may occur as direct manifestations. Beyond the basic ECG, treadmill stress testing may reveal a QTC that remains unchanged or shows minimal adaptation to heart rate variations, with a QT-HR slope less than 0.9 meters Beatman. Advanced echo techniques like speckle tracking and tissue Doppler imaging might reveal impaired systolic activity. The role of electrophysiological studies remains controversial. Some studies report brief refractory periods and susceptibility to induced arrhythmias, but they don't reliably predict SCD risk. 7 genetic mutations are linked, but the genotype-phenotype correlation remains unclear due to the limited number of confirmed cases.
Is there a specific scoring system for SQTS like there is for LQTS?
Yes, there is. The short score for SQTS, proposed by Vilman and colleagues, combines ECG findings, clinical history, family history, and genetic testing. Points are assigned for QTC duration, for example. A QTC under 370 meters earns 1 point, under 350 meters 2 points, and under 330 meters 3 points. Clinical criteria include cardiac arrest or polymorphic VTVF, 2 points each, and family history considers relatives with likely SQTS or sudden infant death, 1 over 2 points. At least one ECG point is required for other criteria to apply, making the ECG absolutely central to the diagnosis. It's important to distinguish SQTS from Kubota syndrome and early repolarization syndrome, which can have similar ECG features. Careful differentiation is key. ICD therapy is the cornerstone of management, especially for symptomatic patients or those with a positive family history who are supporting findings from other tests. It's crucial to understand that a negative genetic or electrophysiological study doesn't rule out the diagnosis or future risk. Pharmacological therapy, such as quinidine, is considered most effective as it prolongs the QTC and ventricular refractory periods.
Disopyramide is also a viable alternative, particularly for SQTS1. Other antiarrhythmic agents have generally shown limited efficacy, and certain drugs like abulide and sotalol have been shown to be ineffective.